Good morning. I'll be presenting on behalf of Medicine 2. The title of my presentation is The Addled Mind. Presenting Mrs. S. She's a 47-year-old housewife from Tirupattur who presented with complaints of headache, vomiting, fever, and altered sensorium for one day. So the headache was a holocranial type of headache. It was very severe. It was only relieved with IV analgesics, and also the relatives mentioned that she had to tie a handkerchief over her head to relieve the pain. She also had 4 episodes of vomiting in one day. It was non-bilious, non-bloodstain, and the headache was slightly relieved after vomiting. She also had low-grade fever, which was intermittent, and that same evening she had developed altered sensorium. So there was increased aggression, irrelevant speech, and decreased verbalization. She did not have any history of seizures or any focal neurological deficits, no history of head trauma, no recent travel, no skin rashes, and other history was not significant. She's a known case of diabetes for more than 6 years on OHAs, and she's not compliant with the medication, and her sugar levels are not been under control. She's also a known case of bronchial asthma for last 5 days on MDIs. So coming to examination, she was tachycardic on presentation, but there was no fever at that time. The blood pressure was slightly elevated, it was 150 by 80. And her GCS in the emergency department was E4, M5, and V2, and there was neck stiffness that was present. So summarizing, the patient has presented with history of acute onset of fever, headache, altered sensorium, and neck stiffness. So what we considered was an acute meningoencephalitis, probably bacterial and viral were higher on the list. And it could have been a heat-related illness also. So coming to the initial investigation, the patient had an elevated WBC count. It was 23,500 with neutrophils of 92. She had a HB of 17.4. And as you can see, the sugar levels are not controlled. HbA1c was 11.9. So since our suspicion, we had a high suspicion of an acute meningoencephalitis. Fundoscopy did not show any features of any papilledema. So we went ahead and did a CSF analysis in ED. The CSF count was 5,900 with neutrophils of 94. CSF protein was elevated, was 415. The CSF culture did not grow anything. We had sent an antigen for pneumococcus, and that became positive. Later, the blood culture also grew streptococcus pneumonia. We did an MRI brain, which showed features of meningitis with multiple tiny infarcts, suggestive of an endarteritis. There was also pyogenic material within the ventricles. And there was also a focal bony defect involving the left olfactory groove, which was a site of CSF leak. So on probing later, we found out the patient did have history of CSF rhinorrhea for 2 years. Now coming to our diagnosis, this is a case of an acute pyogenic meningoencephalitis due to pneumococcus, and there is a primary pyogenic ventriculitis with a CSF rhinorrhea. So what I would like to highlight about the case is about this primary pyogenic ventriculitis. So what is ventriculitis? It is an inflammation of the ependymal lining of the cerebral ventricular system, and it is characterized by suppurative fluid within the ventricles. So usually the most common cause of this ventriculitis is iatrogenic. So if there's any neurosurgical procedure, EVD, shunts, that is when most people tend to get ventriculitis. But also it is seen as a rare complication of meningitis. So when it is seen as a rare complication of meningitis, it is usually seen in children. So in adults, it's a little rare. So the most common pathogens that are associated with primary pyogenic ventriculitis is streptococcus pneumonia, Neisseria meningitidis, Tephilah, and the other organisms. So the risk factors that have been described in few observational studies were if they were immunocompromised, like if they had a HIV. It is usually suspected when patients are treated on the appropriate antibiotics and there is no clinical improvement. So what are the complications of pyogenic ventriculitis? So they tend to have a neurological sequelae that is usually permanent. So they have cognitive impairment, gait disturbances, paresis, behavioral disorder, or epilepsy. So this is a retrospective cohort study where they had taken around 98 patients. So in the study, they found out that the most important risk factors that were associated with higher mortality was if the age was more than 65, if they had a high CSF proteins, high CRP values, positive CSF cultures, and if there was features of cerebral vasculitis. And the most common MRI findings are, so like in our patient, she had a debris within the ventricle. So that's the most common MRI finding. They can also have complications like hydrocephalus, vasculitis, strokes because of this. So these are few observational studies. In these two studies, they have found out the presentation is very similar to how our patient presented. And also they found out that infectious endarteриtis is quite common in pneumococcal meningitis. And this is what our patient also had. So coming to the treatment, since it's a rare disease, there is no specific guidelines for the treatment of primary pyogenic ventriculitis. There is an IDSA guidelines, but this is for healthcare associated ventriculitis, like post neurosurgical procedures. So the exact duration of treatment is not very clear. But from the few observational studies that are there, they have recommended 6 to 12 weeks of antibiotics along with steroids. So coming to steroids, what is the role of steroids in an CNS infection? So this is a systematic review that actually showed that the use of steroid is so it did not have any benefit in improving the mortality, but it reduced the lower rates of hearing loss and other neurological sequelae. But there was other studies that had shown specifically pneumococcal meningitis that dexamethasone had shown to reduce mortality. So this has been recommended by IDSA. So coming to vaccine, so this is another meta-analysis which showed that using pneumococcal vaccine actually is protective in preventing invasive pneumococcal disease. So CDC recommends for the following conditions. I just highlighted two. One is CSF leak and diabetes mellitus. So coming to our patient, what risk factors did she have? She had uncontrolled diabetes, so sugar levels were elevated, HbA1c was elevated. She also had a CSF leak. So she was empirically started on ceftriaxone, vancomycin, acyclovir, and dexamethasone. She received 2 weeks of ceftriaxone and vancomycin, and she is planned for 6 weeks of ceftriaxone. There was no evidence to suggest prolonged use of steroids in this patient, so she was treated with 4 days of steroids. We had got ENT and neurosurgery consult. Since there was no complication like hydrocephalus, there was no intervention from neurosurgery side, but both have plan for a CSF leak repair post the treatment of the meningitis. So we also controlled her sugars with insulin. So learning points, one of the complications of a bacterial meningitis can be a primary pyogenic ventriculitis along with other complications. We need to know when to suspect a primary pyogenic ventriculitis and management.
Few questions. Did she have any previous trauma or a head and neck procedure?
No head trauma.
Previous similar meningoencephalitis?
No.
Any questions or comments?
It's a good practice to add the risk factor in the clinical syndrome so that our differentials narrow. So acute meningitis in an adult with CSF writing should have been a clinical syndrome so that differentials become less unnecessary, treatment become less unnecessary. 1. 2. When you're discussing, try and discuss on one point. Don't jump from points to points. It doesn't convey anything. All the principles. Try and pick up one point that you want to convey to the audience here and please highlight on that. Everybody seems to be jumping from one topic to the other in the field of subject that you're presenting. And that's not really helpful.
Can you please show that CSF analysis values? What is the gross appearance of the CSF?
It was turbid. It was taken in emergency department, but they said it was turbid.
The classical description of CSF in patients with ventriculitis is frankly purulent. But demonstrated unequivocal evidence on imaging source. And then she had a GCS of 13 by 50. Usually they present in a deep coma unresponsive. Very good diagnosis. Why was she not adherent to antidiabetic therapy?
Sorry?
Why was she not taking an antidiabetic drug? And the cause of this CSF leak? You said no trauma. It's
no
not
trauma.
a congenital defect. No?
It is a defect. There's a bony defect.
But when a 47-year-old manifesting for the first time,
She had complained of some discharge only for the last 2 years.
Did she have any sequelae? She's still on antibiotics.
No, so she had come to OPD and sensorium is 15/15.
Hearing loss, nothing else. We'll move